Lou, Brian, Mike, as you listened to each other, was there one particular thing that struck you or a question that you might have of one of the other speakers?
Well, I was struck by the unanimity with respect to the pace of change that we need to confront. And this has certainly been a key issue for the board. And Brian confirmed it from national perspectives. Lou, I think, also confirmed how much things are changing around us and how we need to be flexible to try to respond appropriately.
Great.
Brian, I would like ideas from you on what you have seen rural hospitals do to adapt to this tsunami of change, where you think we should go. Obviously, we want to help the community, but the whole thrust of healthcare reform in the U.S. today is keep people out of hospitals. So what is the appropriate role of hospitals, number one? Number two, isn't it obvious that we need to compete head-to-head with TOPS, which is our ASC? Otherwise, we cannot survive. Point of information, the reason is that insurers pay surgeons and radiologists tons, and they pay pediatricians, internists, and family practitioners zilch. So the only thing that makes a profit for a hospital is the surgery. And that's why all hospitals are using their surgery revenues to cross-subsidize the emergency room, the OB, the ICU. And if we lose our hospital revenues from surgery to TOPS, we don't have the money to pay for what you all need. Third point is...
I'm cutting you off.
No. Third thing is bargaining with ever more concentrated insurers. These things go together, Jonathan, and we are facing them, and it doesn't do a lot of good to just give general points. You have to get down to what we do.
And there are 150 people in the room, so thank you for that.
Well, you've certainly hit all the key points. So, is this better? I'll do this. You've certainly hit all the key points. If this was easy, it would be solved. And if there was one model, there'd be one model, and you guys would be out hiking right now. But I think we need to go back to the principles, and that is that we have a very inefficient healthcare system in this country, and it's multifactorial. I mean, there's a lot of reasons for that. So the question is, how do you design systems of care that fit into the local circumstance? And it's going to be a combination of communities coming together like this to design those systems. It's going to be also making sure that the advocacy efforts are aimed at one size does not fit all. And that's the role that organizations like the American Hospital Association and others need to take. And that's why we're embarking on these community conversations, because I don't think that the voice of all organizations has been heard completely. This could be a room of academic medical centers, right? And we'd be having generally the same conversation, because academic medicine is under enormous pressure right now. And as Lou described, that's the pipeline for a lot of folks that are going to care for us. So the models that I've seen in my travels most recently are the communities that are engaged, the communities that are trying to influence policy and decision making at their legislative effort. And I know at the beginning you recited the elected officials that were not in the room. Hopefully they've gotten in, because ultimately that's critically important to move forward. And then finally, it's going to take time. I think what Lou said, this is going to be iterative change. I mean, there's not going to be a single point where there's going to be a tipping point. You know, Malcolm may not be right on that. But I do think that this is going to be iterative change, but we've got to keep our eye on those principles. You know, regarding competition, so I've always found that the best way to deal with competition is to be better, right? And so the reason that limited service providers exist and what is touted is because we don't make it easy as hospitals or healthcare organizations to care for their patients, right? That's usually the one piece. And the second piece is it's a way to make more money, right? But as a community, you have choice. So when your doctor says, go to my owned surgery center, do you really have to do that? Because you know what? If you say no, it doesn't happen. And if a bunch of you say no, then those places don't exist anymore. So consumers need to behave like consumers. And that's the best way to deal with this. And the hospital has to provide outstanding care, and it has to be as efficient as possible for those organizations. If those two conditions exist, if the care is great and it's efficient, and you're saying no as a consumer, I think, quite frankly, it's game over for those kinds of organizations. And that's where the community needs to step up. Insurers, I could do a whole talk on insurers. That's why there are insurance commissions. Network adequacy needs to be a big portion of what comes in. But you have a very unusual state here in terms of, some of the opinions about regulation. So, but I know in the other states where we operate, because we're in Maryland, DC, and Florida, we certainly are working hard on network adequacy.
I think in Wyoming we could do better in the political realm. People don't realize how small time the legislature is in Wyoming and the level of ignorance among the populations and many of the legislators. The Wyoming Hospital Association, if they were on the ball, would have an ambassador out there right now going to every community, getting with the community hospital, getting with the legislators, doing the kind of presentation here so it's more widely understood in Wyoming. We've always been leaders in Wyoming. We're the ones who thought up the sales tax, optional sales tax, which took us years to get it through. If you look at the history of legislation in Wyoming, we've always been on the cutting edge, and we could be now in the political realm if we got it together with the Wyoming Hospital Association, etc. So I would say that would be an area for innovation for us.
Let's have Leslie organize that. Go Leslie. In your spare time.
Do you want to respond first? Anybody?
Good point.
Yes, I'm Elizabeth Masick, and I'm on the Hospital Board of Trustees. One of the greatest strengths of our wellness program is our focus on preventive care. And at the end of the day, we all know that preventive care will solve a lot of these problems. I have a question for Brian. How can the public health infrastructure that I believe has been so underutilized help transfer the burden of costs in hospitals as we go from this volume to value paradigm? Or is it even being discussed?
Sure. It's a great question, and I would argue it's not just the public health infrastructure, but it's how you do that. We talked about one of the attributes of the ACA was to create models of experimentation in different communities, and I'll use this as a particular example. So one of the things that used to really upset our dean a lot during the conversations about the ACA is that Obama would always talk about Mayo and Geisinger, right, as being these models of efficient care. And the dilemma with that was if you look at the context of social determinants of health and why certain communities suffer more than others, Mayo and Rochester and Geisinger and Danville, it's not East Baltimore, right? It's not East Baltimore. It's not a food desert, right? The predominance is single led households. I mean, I can go on and on. So we created an experiment. Now, the experiment was funded by $19 million of CMS money. But what our premise was is over a 3-year period of time, if we interact differently with the community for patients who have high chronicity of disease or very unusual conditions, can we bend that cost curve? Can we improve their health? Can we improve their outcomes? And we've learned a lot. We're 2 years into it, and we've learned a lot about how do you work differently with community resources. And I used this example in a discussion last night. A lot of these folks had no ability to communicate with us, right? And so they'd only end up with their diabetes when it was out of control in the emergency department. So we gave them phones, right? We gave them phones. And our care managers would call them. But when they saw Hopkins on the caller ID, they thought it was a bill collector, and they wouldn't answer the phone, right? So then we had to retool it. Once again, we had a lot of community engagement. We had to retool it. And we created block captains in these areas. And they were people who weren't healthcare people, but they were people who the community trusted. And they had this belief that if they could stay connected with their community members, they could do it differently. And so, what is going to happen when the funding runs out, right? That's the dilemma. And how do you sustain these learnings? And so it's this iterative change that we're going through. This innovation, CMS Innovation Grant, is intended to be able to take these learning experiences and figure out how to try to bake those into some of the financial models that exist. Medicaid's a prime example of that. If Wyoming could get beyond some of the politics of Medicaid expansion, you can begin to experiment with Medicaid in ways that you can't before. In Maryland, we own the largest Medicaid managed care organization in the state. We fully insure and care for almost 225,000 Medicaid enrollees. Because we have first dollar on that, we're able to create systems of care where we do things like you asked, and we create those engagements, and the math works. But you've got to be able to innovate and take those learnings. It's going to be an iterative process, and it's got to be enabled by regulation. And that's to your earlier point about advocacy and education. That's going to be critical during these periods of time.
Well, I work my way back the room. Lou, I got a question for you, and that has to do with, it seems like in the last several years, whether it's yoga studios or training facilities or alternative care, there's been a variety of different types of alternative, non-traditional care, complementary care types of things popping up in the community. And I would just like your observation on what do you see in terms of where those types of alternate modalities are going, and how does that factor into what the hospital is trying to do or might do as things morph and change so quickly in this community?
Well, I think that we've learned very quickly that, maybe not so quickly, it's been a lot of years, that integrating these alternative things into the hospital actually works. So if you come into St. John's, you can have healing touch. What's healing touch? I don't know what healing touch is. All I know is it works, okay? That you give a patient this healing touch before they have their surgery, they go through surgery and come out better the other way. If you give it to them after they have surgery, I'll tell you a personal story. My wife had surgery this year. She said, I don't think so. I'm a psychologist. I'm not into that. It was wonderful for her, okay? So those are things that we can and should integrate. Massages for women during labor, using a water tub for them to be able to labor in to reduce that. These are all things that should be integrated. We're fortunate we've got a community out there and a number of the alternative providers who are willing to work with us and collaborate. So we need to integrate it more and more.
Hi, my name is Joel Albright, and I'm on the hospital board. I have a question, an easy question for Brian. In this county, we've had something like 2,250 people sign up for coverage under the Affordable Care Act in the exchanges. And one can estimate that approximately 2,000 of them have subsidies under the Affordable Care Act. So if the Supreme Court decides in the case of King versus Burwell to eliminate subsidies, what is the American Hospital Association thinking about what should be done next?
Sure, it's a great question. And thanks to Julia, my daughter is one of those 2,250. and she did get subsidized because on Jonathan's chart, she's a service worker. Thank you, Julia, for doing that. You know, that's a big issue. The general sense that we have at the AHA, and I start my weekend of board meetings tomorrow in DC, where we're going to talk about this in more detail. The general sense that we have is that there's going to then need to be a state-by-state response to deal with this, because there is going to be a huge outcry in this country if we move away from subsidized care in that regard. And this is a very narrow, technical wording issue that occurred in the legislation, which is what happens when 25-year-olds with no experience write the legislation. So, you know, we're working on that. We are going to try to mobilize we are in the process of mobilizing the state hospital associations, to your earlier point, to do that. But this is going to be a difficult time. But we believe that there is enough momentum behind this that we're going to be able to work through that if indeed that is the way the Supreme Court rules. So. And that was not an easy question. So.
I think this is probably for Lou. I'm Karen Terra. I received an email request for to fill out a survey on whether I would be interested in having additional health services provided by the hospital, such as trainers and meditation, and on a cost basis. And I'm wondering if that, where that is, because I think that's an exceptionally good idea for a profit center for the hospital.
Julia, can you enlighten me on this one?
I'll gladly do my best to handle it. Thanks, Karen. I'm Julia Hughes. I'm going to be speaking next. I'm the director of the Wellness Department. The closest that I can get to when it comes to thinking about the survey you may be referencing would be our health risk assessment, which is something that all of our Worksite Wellness employees fill out on a regular basis. There is a final question out of the 65, I want to say it's question number 63, that asks about what are the different wellness programs you'd like the hospital to offer to you. That would be something that we'd be offering to the Worksite Wellness population, though. The other survey that springs to mind, unfortunately, we've done quite a few surveys, as many people know, in the last year. But the other survey that does spring to mind is the quality of life survey that Sarah actually conducted last summer. That, however, did not have a question like that. We will be talking about our Worksite Wellness programs, though, in our next presentation.
But I don't know that we're doing any email surveys like that.
I'm not aware that we're doing any either. That the link
I'd
was one
love
that
to
did
see
go
it.
out to our Worksite Wellness client.
My name's Jay Barley, and I think the two biggest problems that we face as a nation that we can solve are healthcare and education. And I think they should be working together too. And I think that, if we educate the little people, they're incredibly influential in the big people. As Madison Avenue a long time ago discovered. And if we can get them educated to live a healthy lifestyle through the schools, things like more exercise, there's hardly any, but, and different wellness type things, and nutrition, we could do through our culinary arts program at the high school, and have them do one meal a week or something, and their peers will probably come and eat it, and even show them how they prepare it, just cut everything up as they go through the line, things like this. But I think we have to deal with getting our young people much healthier in the long run, and that's the only real solution, in my mind, to really solving these problems. Thank you.
Jay, I think you're absolutely correct, and I'm happy to say that in the wellness stuff that we're doing with the school, they are now asking us to come in and do some of those activities with the students, and there is a group of students who are cooking and using our facility to do some cooking so that we can then have them transpose what they're learning to be able to benefit our patients.
Obstetrician gynecologist. My question is for Brian, and you know where this is going, but part of with all the things that you talked about with healthcare is you're asking providers to see more patients, you're asking hospitals to take care of more complex patients with more chronic problems that cost more money. So my question, I guess, is since you're asking providers and hospitals to do more for less, part of the reason that as a provider I used to do more is because I didn't do more, and I didn't do everything, I didn't do every test, someone may come back and sue me. So I guess my question is, what is the American Hospital Association doing to affect changes in the legal system?
Sure.
It's not an easy question either, I know.
Right. And once again, that's a state by state kind of an issue. So defensive medicine, the cost of defensive medicine is really what you're describing, and that's a very real issue. And there are various estimates of unnecessary utilization driven by that. One of the things that's really important, though, is that as a medical community, we come together with clinical guidelines that actually describe what standards of care are. You know, that is hard, but it's not impossible. And I'll give you some concrete examples of that. Three of the health systems in the city, to a point where we've had to convene a statewide task force to try to do that. But at the end of the day, what we've got to try to rely on is what is a standard of care and how do we collaboratively develop that. So we've put together this concept of clinical communities, and those clinical communities come together, not just with doctors, but with nurses, with other providers, ethicists, et cetera, to try to define that. And I think that the work that we need to do in medicine is not say, just trust me, I'm a doctor or I'm a nurse. It's to say, okay, these are the evidence-based guidelines under which we're practicing, and this is the standard of care. Oftentimes, and you're not going to like this answer, but oftentimes, you know, we as medical providers don't engage communities in these conversations. We don't engage patients. We don't engage families. So this concept of patient and family-centered care, how do we create guidelines? Once we get credibility that we are truly policing our own and that we are adhering to standards, then I think that tort reform conversation becomes more credible. But until we do that, I think we're going to continue to beat on the same situation over and over again, and it is a statewide process. So what we're doing at the American Hospital Association, and we're trying to do it in conjunction with our colleagues at the AMA, is to try to encourage and engage organizations to go through that process. And I don't know, Lou, you're much more knowledgeable about this than I am, if you'd agree with that. So.
Totally agree.
Hi, my name is Lori Rue. I'm a local small business person who has had my own nightmare with the Affordable Care Act and buying individual health insurance. But I won't even bore you with that because we'll be here for days talking about that. But my question is more about local servicing at the hospital and how to decipher through your billing from your insurance company some of those bills that you get, because if you go into our hospital for some type of testing, you know that you're going to get a separate bill from your doctor, from the room that you were in, and then ultimately, if you had an MRI or an X-ray or something like that, from the radiologist. Which group of people are in network? Which group of people are out of network? We live in a state where we are very limited with our health insurance options, and why would some of those groups not be part of the network? And you would not be given a choice as to a physician that may be. For example, in radiology, you get a bill from the radiologist, and those radiologists are not in the network. However, they are the people that are in the hospital, and you don't get to choose. somebody in network or out of network for that service?
I think I purposely avoided this issue because it is such a complex morass, and I can tell you, having worked in this industry for all years, I can't understand my own bills, and we spend a tremendous amount of time trying to help people understand. It's totally a mess, and it shouldn't be the way it is, and everybody's to blame on this one. The federal government with their rules, the legal people with their rules, the insurance companies, the way they do things, and a lot of what the insurance companies put out is because the regulators are looking at every word that they have, and so that book that you get that you don't read, and I don't read, from your insurance company that explains a lot of these things, if you could ever find what you're really looking for, are so complex that it doesn't work. This is an area that we're spending tremendous amount of money for no end, having counselors at the hospital to help people with their bills, with people calling me up to say, what do I do with this? I don't know the answer to it other than it needs to be part of the total health reform. We're working towards that. There's now not a separate anesthesia bill from the hospital, but if a doctor's in private practice, they're going to send their bill. For those doctors who are part of our system that work for the hospital, you get a bill from St. John's, but I don't have a good answer for that. Brian, you got an answer?
My answer to this is it's a very real problem, and it's not just here in this region. It exists all over the place. And it gets back a little bit to standards that are set. And once again, this is a state-by-state issue. But network adequacy and holding insurance companies accountable for network adequacy when they're selling product is really important. And I'm talking about this now coming from an organization that we own insurance. We own insurance products, and so this is something I deal with every day. But in some states, network adequacy is so broadly defined that the insurance companies can get away with not having those services based in a region. And that becomes a problem because then the providers are getting contracts that they just can't live with financially. And oftentimes, particularly in rural settings, it becomes an access issue. And so when you're doing contracts, and you're looking at these sole source groups that you're describing, because they're not getting adequately paid and they're not being held, and the insurance companies aren't being held accountable to have an adequate network, it is a self-perpetuating problem. So what we're trying to do is to develop network adequacy standards that then can be adopted state by state in order to deal with that. That being said, though, we own part of this problem, and that relates to pricing transparency and being as clear as we can about this. And once again, if I'm in Louisiana, I'm going to get thrown out of the room at this point in time by my colleagues when I say pricing transparency, because you should know healthcare is one of the few economic transactions that you have where you have no clue what you're buying and how much it's going to cost, right? And so we need to work hard on this issue of pricing transparency and make it as clear as we possibly can. But you put your finger on a big issue, and as Lou said, is something that has been very perplexing. But once again, I think as consumerism is kicking in more, if we're not transparent with our pricing and we don't get network adequacy, your smartphone's going to do that, and none of us are going to be happy about that. So.
Well, that takes care of the question and answer period. Would you please join me in giving a